for watching. Please like and subscribe to help us spread Teepa's positive approach message around the world. And don't forget to click the bell to get notified when new videos are posted.
Well, good evening or good morning, no matter where you are, because we have folks from all over. I'm Teepa, and we have the PAC team here. Some who are actually working with PAC every day, and some folks who are supporting PAC every day, and some folks who are independent practitioners, and some family members, some people who might be living with dementia. And we've got a whole host of folks out there in the YouTube world. And we're really curious about what people have to ask. And we have Beth Nolan, who will sort of be happy to do some role play, but also respond to things that people might bring up in chat or in questions. Matthew will be watching YouTube to make sure that people out at YouTube can offer things in and raise questions. We have also Cheryl Buchholz, who is up in Canada, but she doesn't mind answering questions from anywhere. We have Lynn Moore, who's down on the coast of North Carolina, and it's probably beautiful but hot, hopefully. And we have friends from all over the place. So we're going to start off. Rachel is the other person. I mentioned her before. Rachel is the person that gathers questions for us and figures out, okay, who's going to start? So Rachel, kick us off with Ask Teepa whatever you want to ask her, and it's sort of a stump the chump kind of phenomenon here. So let's see what we got going.
I don't know, Teepa, maybe I should come up with a question. No, so our first question is from Kay, and she was asking because her person that she's supporting is in a Ruby gem state, and she has been very skillful at using hand under hand, I guess successful in using hand under hand for supporting him to eat and to drink. But his dementia has progressed and his strength in his hand is really tight and it's kind of painful for him to move. So he's kind of lost motion in his ability to move his hands. So they've tried to use their hand on his wrist or forearm to keep some connection, but that can be painful. So I think we're trying to figure out how do we still get the idea and still connect without causing more pain.
So I'm actually going to pause on that one for a second and go see if I can find a partner here. They're out on the front porch. So I'm going to go do that for a second and see who else here could do that for a second while I go see if I can Shanghai somebody up to do a role play with. I'll be right back, Kay, I promise.
So in the meantime, maybe we could bring people up to speed because we have a pretty informed question asker in this one. So we talked a little bit about hand under hand, it sounds like. Is that the gist of it, Rachel? Well, one of the things that Teepa is going to go show with a person, which is much easier, is a technique that we use really commonly in PAC called hand under hand. And it's a way to connect the brain and the body when that messaging system is a little bit, it's kind of going some haywire. But it allows the person in the position of being supported to actually participate in their own care. And it's amazing the differences. I get so many videos every week. But basically what it looks like is if the person's hand, who normally would take their own cup and drink, that in fact, we start off in a handshake and we move to a hand underhand position. And you'll see a bunch of team members here doing it because they do it pretty regularly on Zoom. If you want to try this feeling at home, you can go ahead and take your left hand and put it towards the screen. And then take that pinky, because this is going to be pretending to be somebody else's hand. Take that pinky up and you actually take your own right hand and do a shake. You shift that right hand straight up and lay it down. So let me do that one more time for our non-kinesthetic learners because it took me so long to learn to do this in a weird way. Left hand facing towards the screen. Hold that pinky up. I had to do it manually. Take your right hand and give your other hand a handshake. So you'll come with your right hand in front of that one. It's sometimes hard to look at it in the mirror and do this. And then swing the right fingers up and lay it down. And in this way, you can actually help yourself eat as you're trying to feel what it feels like as the person who's in concert with somebody else assisting. So that's the technique. And Teepa, I'm going to pass it back to you because it sounds like you couldn't find other humans around.
I could not find other humans. And so I am going to actually pause still on it for a few minutes, and I'm going to go find a video. PAC skills make the difference. If Beth, do you have that available to you?
Yeah.
Would you mind looking up my work with Edna? Yeah, because that will give us a really clear sense of how you do this. So one of the strategies that we have is and so what's really important is when I'm supporting the person in this, what we would be doing is helping the human being to my side eat. When they're no longer opening their hand, we can still have them put their hand on our forearm. When they can no longer tolerate moving their arm much, then we have to really look at how we might position ourselves even more differently, and that we really come in close connection, trunk to trunk, and that we're giving more signals through our trunk and through the shoulder girdle than we're going to be giving through our arms and our hands, actually. So I am still going to see if I can get somebody to come back. But Beth, were you able to pull up Edna?
I was. And what I thought I'd do actually first is bring up Lucille so people can see it in a more traditional hold first.
Yeah.
So this is a woman who, and Teepa, you can go ahead and set this up if you like.
Yeah, so this is a lady that I was asked to take a look at because what folks were anticipating, they thought that it was time to have hospice involved because she was not eating much at all and had lost 20 pounds over the last month. And she was moving her face away, not willing to take the spoon in her mouth. And so they were thinking the issue was that she didn't want to eat. And what I discovered, the issue was that she couldn't figure out what they were trying to do. And so by and she had very low muscle tone because she's had 13 strokes since her dementia started. She had stroke after stroke after stroke. So she has zero active movement in her body. She can't actively move her body much at all, especially her arms or her trunk. So she's total assist for movement, with the exception she can hold her head upright and she can chew when she understands what we're doing. And she munches, but she really can manage to chew. And she can open her jaw, accept the food in, and then be able to manage it. So I'm actually supporting under the elbow with my hand that's holding the bowl, and my hand is in her hand, giving her lots of information about scooping with the spoon, preparing the bite. I'm talking to her, and it doesn't seem as though she's listening that much, but it turns out she actually is. So what's happening is people are really fascinated by how well she ate. And so we went from a 20-pound weight loss within the next month, she gained back all 20 pounds. Because it wasn't that she didn't want to eat, it's she couldn't really understand what people were trying to do is help her eat. She thought they were trying to shove stuff in her face. And she was turning away and fighting that motion because it didn't make sense. So by engaging her hand. And so that's where it sounds like Kay had success before with the person she was helping. But now this gentleman's, and it's very common at the end, later state of dementia, that people have a lot of flexion, adduction, and turning inward, what we call internal rotation. So the hands are sort of over and across. Is this similar, Kay, to what you have or something different? Tell me what you've got in the upper body whenever you can unmute.
So my brother, he's got a lot of, it depends on his moment. So we basically have trouble. We can do the hand under hand, but he has a lot of people supporting him. And the main problem that they're having is that his grip is so tight that it's quite painful for them.
Yeah.
Whether it's using the hand under hand or holding the wrist.
Okay.
So it can be quite tight. And as he tightens, he will tighten his forearm and give us less flexible,
Gotcha.
movement.
He's not able to easily move that in his forearm. So his isn't that he's gone into full contracture mode.
Not yet.
It is really that he's very strong in his hands. And when he tenses his hand, he also pulls his arm into a very rigid posture.
Yeah.
And he's holding on for all he's worth, but he's, again, not getting the idea of eating, the eating phenomena. So what we can try is laying our arm on his arm. So not asking him to do anything with his arm, but laying our arm, and I'll try it with, I have like a not very effective doll. Let's take a look at Edna, and I will go get the ball that,
This side, we're gonna start with this side. And I know it's not the most comfortable thing, is it? Let me go to the other side and see if that works better. Let's try the other side. Okay, we're gonna try over here.
And Edna, again, is someone who's had vascular dementia and several strokes.
I know. Here you go. I know. Edna, let's brush your teeth. Here you go. Got it? Open. Ah. Open. That's it. You got it. Yeah. Perfect. Yeah.
So
Good
what
stuff.
I'm,
You're doing good.
what you
Let's
see
do
me
this
doing
side.
with this hand is giving
That's a
her
lot, isn't it?
information through my body. It's not directly about what's happening with my other hand. Because she can't move that side at all. And she has a lot of what we call extraneous or choreoathetosis. Like it's a movement of almost a writhing pattern when she tries to move. It's not a coordinated fashion pattern. And she can do some stuff, and then it gets really hard for her to stabilize her head. And it's what we see in cerebral palsy. Some people who have cerebral palsy will see that kind of writhing motion. So I'm gonna try a little bit, see if I can get my assistant here. I'm still hopeful somebody won't come back, but I think they went for a while. What I'm gonna do is I'm gonna take this forearm and I'm gonna place it on the arm. And when I do this, I'm gonna make sure that my arm, this forearm of mine, is on the person's upper arm so that they're getting the message of movement in and to the mouth. So when I have a utensil, it's again, I'm not involving the hand and I'm not trying to get the arm to move. But what I might do is hold the cup slightly below, so it's a short travel distance. So I'm not actually asking for a lot of travel, but I'm actually giving information through my body. Scoop, bite, scoop, bite. But I'm more up on the upper body, and I've eliminated using the hands as much because when you try to use the hands, it ends up resulting in a really tight grip and a tensing.
Yep.
We tend to see that more, frankly, with Lewy body disease than we do with many of the vascular dementias, but it can happen with vascular, but I've seen it more with Lewy body.
Teepa,
Yeah,
I have my sister here if you want us to try that in person.
sure, that would be super, Rachel.
So lean back a little bit. Kind of close, see, then cutting off a little bit. And then kind of.
Can you tip your camera? There you go. Thanks, Rachel. So notice as Rachel is reaching around and doing things, she's keeping a hand on her sister, so her sister knows where she is. And now Rachel is coming in really tight with her body, and she's giving a lot of contact through the trunk. Can I highlight? Let me see if I am able to, let me see, let me make Matthew, oh, okay, Matthew's on it. Okay, I was gonna say I'm not the host, actually. So here we go. So everything that Rachel does, she's telegraphing through more her trunk than it is just her arm. Because her body is so in contact, her sister is getting a lot of neurological information. So Rachel, can you have your sister keep her eyes closed and then open her mouth when she feels the spoon coming up really close? And notice how accurate the brain is at noticing that, even though the arm isn't even involved. And it's because Rachel is telegraphing all the micro muscle movement in her body to her sister. And so now if you switch over and you do something else, like the, Rachel, look at me, switch and do this. No peeking. And what happens is that it's going to be a drink this time versus a spoon. When the thing gets close to her mouth, the way Rachel's body is holding the thing, her brain starts translating that, oh, drink. Now we're switching to a drink. And so it's not a surprise that it's a drink versus a bite. So it's 5 bites and a drink, 5 bites and a drink, drink, 5 bites and a drink. And so now, because Rachel never let go, her sister now knows that she switched back to the bites. So it's amazing when we make connection through bodies, how one body communicates to the other body. So it's not just about the arms and the hands. It can literally be about the body. Now, if he is really grabbing, like he really wants to make connection, what I would try to do is make sure he has something to hold on to and that it's got some texture. So I tend to use things like rice socks or corn socks, putting something that can be and give him some feedback. So something like Rachel's going to use a washcloth, which is in the moment you could possibly do that, but I will actually give somebody like do something like a rice sock. When you squeeze it, it gives a little bit and allows you to have that sense of a person, squeezing a person, which can feel pretty good to someone who craves sensory input through their hands. Thanks, guys. Very helpful. Kay, thoughts?
Thoughts? No, that's great. We'll have to do some work on at the minute for his, at the minute for eating and drinking, he's in a chair. The arm rest is going to be in the way to get really good body contact, but
are they removable armrests, Kay?
Not on his dining chair. We are waiting for a new wheelchair, and that will be more comfortable for him to sit in. So that will have a removable
armrest.
Armrest, except that the side panels to give him support so he doesn't slump will get in the way. The thing that I'm sitting on is an elevated stool. So there are just like high stools that if I sit on the high stool, I can probably situate my body for short periods of time. I wouldn't want to do it for a long period of time and it'd be really uncomfortable, but I might be able to get in close enough that way. But you probably will have to mess with it and play with it a little bit. Maybe when he's not in the dining chair, one of your folks could sit in the chair and you can sort of play with them to figure out how to make it possibly work. Because sometimes the devices we put people in for seating make it hard for us to engage with them in a way that makes sense when somebody is, Okay. And Beth is looking to see if she has a picture.
I do actually.
I haven't done it. It's just.
It was surprising how easy it was. So he's in a chair and there's a big foam pillow that's quite firm between him and that side because he had vascular dementia and he would go over really far. And so we got him propped up and my husband doesn't quite know what to do with the other hand yet. And I think we've all been there. But he was, obviously the grip is a little different from what you're talking about, but I was surprised. Now my husband's on his knees and he's quite tall. But if I had a stool that propped my rear end up to about where his was, I would have no problem getting close enough. My legs would actually be splayed open, not very ladylike. And I would be the back leg, or my left leg would be around the back of the wheelchair, tangled a bit with the wheels, not comfortably, but I could get comfortable. Is that accurate, Teepa?
Yeah, it is. And I probably will see if I can't take a picture in the next couple of days and see if we can't post it up so you can see what we're talking about with somebody in a wheelchair, with somebody in a dining chair. We'll see if we can't do that for you and see if we can get it to be more helpful. Is your brother a fairly big guy or a skinny, thin guy?
He's short and he's not very big.
Okay.
Yeah.
All right. I'll look for a match so that we have somebody who's similar sized.
Yeah. Yeah.
Okay. Cool.
I had asked a question some time ago for a video on how do you help somebody with hand under hand when you're helping them walk, when you're tall and the person you're helping is short.
Yep.
And just as that fabulous video came in to help us, just like that, my brother could no longer stand or walk.
Oh, bummer.
So, yeah. Yeah.
I wish you'd had the info when you needed it, not after you needed it, but
well, I wish that I had asked it earlier.
Yeah. But I'm glad that video went out because it did. I know it was too late for you, but I also know it did help 2 other people because they made comment on it. So thanks for asking for it because it did help some other folks. And we reversed it and we had it if the person was really tall and I was really short, which is the case with my son-in-law, and he's big. Just saying. So thanks for asking, Kay, and we'll see if we can't get you some more pictures that are better matches.
Great, thank you very much.
Cool, you're welcome.
And
right,
the idea of the rice sock, is good. My brother has a tendency to put anything in his mouth.
Yeah.
So I'll have a little bit of. It'll have to be something that he's holding when he's being assisted with eating and drinking. Yeah.
And what I usually do is I use good quality sports socks because they're long and they're tube socks. And I put a second tube over the first tube. So he can really bite down if he's putting it in his mouth, mess with it in his mouth. And I can take that outer cover off. It's like, cool. Okay, keep going.
Great, thank you.
You're welcome. All right, Miss Rachel, we're back. What do we got?
We are. So our next question is, what should you do for someone in AFib with dementia?
Okay. So atrial fibrillation is where the heart does not have a steady, strong rhythm. And so it can do a flutter step. And when hearts flutter like butterflies, what it means is the blood is not being pumped through the heart to the lungs, from the lungs back to the heart to the body. And what that then means is the blood is not getting oxygenated and the body and the brain are not getting oxygenated blood. And if it goes on long enough, it can actually cause cardiac, you have a cardiac arrhythmia that then becomes a heart attack. And the person's heart stops beating. So it has to be converted, or we're worried about it. We don't like it to happen. And some people go into AFib and they don't have any symptoms. And then we start seeing that people do have symptoms with AFib. They get short of breath, their heart rate goes up really quick and high, and they get dizzy and they feel like they're good, and they may actually pass out or fall. So if I have someone who doesn't have dementia, what we can do is figure out what are the signals for them that they need to pause, sit down, notify somebody that's happening, see what we need to do. Do they need to be on try a medication? Do we need to do things? The problem when somebody's living with dementia is that their brain is not registering any of those indicators, because you do have to sort of be aware. It's not like a crushing pain to your chest when you're having a heart attack and you really know it's like an elephant sitting and I can't breathe. It's not that specific. And so people can get themselves in trouble and go into atrial fib and not even know they're in atrial fib until they have either a massive problem or they have a stroke. it is a high-risk condition for stroke, where you start not getting your blood flowing the way it should, and you end up with either having a thrombus or having a blowout, one of those kind of things. So clotting or flowing too much. So one of the things that we've now got is even Fitbits can monitor for atrial fibrillation. The thing that I would do if it was somebody living with dementia is one person would wear the Fitbit, but the person who's going to monitor that person's fit wellness kind of thing would be the one that receives the information in the cell phone. And it can do a notification that the person is in AFib. And you can certainly have that message go to anyone, but if I'm the partner, it would be handy to know that the person's in AFib and we may need assistance. As dementia progresses, the AFib becomes more problematic because what we would want somebody to do for AFib, they may be spurred by their AFib into extra activity. And so they can't settle. They want to move. They have to move. They can't not move. Their brain is telling them danger, danger, and danger, danger is move, move, move. And so they move into flight pattern. And so they're actually moving too much and they have atrial fibrillation, which is making the symptoms worse and increasing the risk that they'll fall and get injured because they're really putting the system under stress and distress. And it's coming from the core of the brain. So that's sort of the setup. So do we have any more information about where somebody is in their dementia or the specific concern about atrial fibrillation?
Yes.
Oh, okay, cool. Ah, there she is, Labriska. Hey there.
Yes. Yes, it's for my mother, and she's, I was saying about emeralds.
Okay, so emerald state, which means she gets caught in
Lost in
cycles.
time and place, and they're saying that she has controlled AFib.
She has control.
Well, she never knows what day it is. She calls me.
Okay.
Yeah.
Okay. So she wants to do things or she doesn't like doing things. Does she feel concerned about her AFib or she really doesn't recognize it as an issue at all?
She thinks the doctors are trying to kill her.
Great. That's good to know.
So she doesn't want to go to the doctor. Yeah. But she was in the hospital and they found AFib and wanted us to follow up with the heart doctor. I could never get her to the heart doctor, so I went to a regular doctor, followed up, and he said she's still in AFib, suggests we go to the heart doctor. But when we were in the hospital, that didn't go well. After the second day, she didn't know why she was in there, and the dementia just got a lot worse.
Yeah, she was in an unfamiliar place.
Treatment. Yeah.
Yeah. Okay, so we have somebody who it's unlikely that you would want to put a pacemaker in because a pacemaker forces the rhythm of the heart. Okay, now it sounds as though, you know, do you want to, is that something you and your mom had ever talked about? If I get to where I'm not able to sort of really know what's going on and they're wanting to do life-saving measures or things like that, I really don't want that done. Or did you all ever talk at all about what she would be interested in doing?
She wants to live as long as she can. She still tells me that body dementia. And so she's had 2 strokes and then a heart issue. They said a broken heart syndrome, they called it.
Yeah. So did she lose? So broken heart syndrome usually happens when people lose someone really close to them. And it affects them dramatically. It's like it took away their will, their heart, their spirit. And so it really broke their heart. And most people who get broken heart syndrome are prone to dying within 2 years of the person that they lost. So where is your mom sort of, if that's sort of the typical scenario, where is your mom in that? Do you think?
Well, what happened was she went to the bathroom
room at a restaurant. When she didn't see him, she panicked, and he had just went to get something to drink. And so she panicked.
Okay, you're breaking up some. So what I think which is not the classic, from what you're describing, I would not describe that as broken heart syndrome.
The whole thing happened.
Yeah.
And we ended up in the hospital.
Okay, can you turn off your video, Labriska, and try telling us it again, because I feel like we missed some really important information. Oh, she's moving to another location where she hopes there will be better Wi-Fi. I'm familiar. So they were in a restaurant and she went to go to the bathroom, and your dad got up to go do something. When she came back, she thought, she didn't know what to think. He was gone. Oh my God, he had died, and she was all by herself, and she had a major panic attack. Is that accurate? Pretty much. Okay, so it's interesting somebody would describe that as broken heart syndrome, because that's not what it classically is used to describe. It's used to describe the death of a spouse, and then the partner is left, and they can't survive without their soulmate. I mean, it's typically used to describe two people who are so close, so heart-bound, so emotionally bound to one another that when one dies, the other one can't survive. And so usually it's that. So what I would say is what she experienced was a post-traumatic stress event. I mean, so she had an emergency event where she truly thought she was abandoned and he died, and she didn't know how that happened. And it was a confabulated event in her brain. And so her brain made up this entire story to go with this. And she truly believed it in that moment. And it resulted in close to what one would call a heart attack, because her heart was absolutely racing at top pace, which was probably when she did that atrial fib and got into this state in the first place. So her heart is never really calmed down from that event. And that means the chemistry of her body is out of whack. And so she's got too many chemicals feeding in an unpleasant way, and she can't seem to get it back under. Given that, I would not expect her to be okay with going to be in an unfamiliar place with unfamiliar people doing unfamiliar stuff. So is there any cardiac doctor in the area that might have a nurse practitioner or somebody who could come to the house and come out, like doctors making house calls, where we would maybe not put her in an unfamiliar place in a high stress situation, just in evaluating her a little bit deeper would be a first step. Because putting her in any other situation, I'm going to make the atrial fib so much worse that it's like, okay, do we give her a heart attack here, or give her another stroke here? Or, are we causing her brain to have little tiny bleeds all over it because of this level of distress? And I would say she seems to be a high-risk candidate, given her history. And so I think what's not happening is the medical community is not being supportive in a way that makes sense for a woman who has both this condition and dementia. They're not putting the puzzle together and recognizing you cannot put her in a situation where she doesn't understand what's happening, because you're actually aggravating the primary condition you're trying to treat. You're going to make it worse, and then you're going to over-treat it. And then when you get her back in the other situation, the medication she's on will be way too much for what she needs in her her more familiar environment. And then we're going to have toxicity, and then we're going to need to go. And then this is like, let's bounce the ball, let's bounce her back and forth kind of thing. Which, anybody else on the team have some other thoughts? Because I mean, that's my greatest concern is, in their effort to dig into this atrial fib, they're going to make it so much worse for her because they keep wanting her in an unfamiliar place doing unfamiliar things. And she's already been panicked by this a couple times.
Yeah, I'm thinking the only likely place that would be likely to do this would be a PACE program, which is a program in the US that works to keep people out of more intensive care. And they might recognize that even going in for a test, even if they can only get a lesser test, might actually be worth it in the home. And that might be some flexibility if that's somebody out there in the world that's dealing with that. I don't know if that's some,
Nebraska, where are you located? Where are you in the world? You're muted, but I'm hoping you will unmute and give us that.
Texas? Let's see how good blip reading is.
Texas.
Yes.
Nice job, Beth. What part of Texas?
We're in North Texas. So Gainesville, Texas,
Okay.
north of Denton.
Yeah.
Ooh, there might actually be a memory clinic then that you could contact through, if you're near Denton, that may actually do something like this and have a conversation about this possibility. It might be worth it.
I mean, I would look for somebody who understands dementia a lot better for you and your mom, rather than trying to do the heart thing, because the cardiac thing, due to her dementia, what's happening is her dementia is getting worse every time you do something. And it's going to get worse because it's stressing the brain and stressing the heart. But sort of, whether a Fitbit might make it worthwhile. So you can even keep track of the atrial fib with a Fitbit. I mean, it's not rocket science. It's not the best science, but it's not bad. It's better than a Holter monitor, which I would suspect she would not tolerate a Holter monitor very well, with electrodes on her body and leads and carrying a little kit around on her chest for like a week. I mean, my experience is that most people who are where your mom is, it's like, that ain't happening. Not going to happen. When she thinks people are trying to do bad things already, they're going to shock me with electricity. And, that's, all kinds of crazy thinking because her brain is so worried. And she's fragile. So it's tricky, but I think it's possibly worth finding somebody who might be able to help you more from the dementia side of the street, if they won't just turf you over to cardiac. And I use that word turf because that's the word they use. It's like kick the ball over there, and then we kick the ball back over here. And that's not at all a helpful way of dealing with a situation like your mom has and you have.
It's probably hard to get into, but probably no harder than getting in to see a cardiologist. But maybe a geriatrician, so a board certified provider who's also specializes in geriatric medicine, would recognize the interplay between dementia, unfamiliarity, distress, and heart rate. And they might be willing to take some of the measures in a less stressful situation and then be able to be the MD who feeds that to the other MD cardiologist, which may be received better than us without MDs saying, I'm not sure the reading is going to be good, much less the stress on my mother.
And the last thing we need to do is have her back in the hospital, frankly.
Right.
Yeah. Okay, well, hopefully some of that is helpful. If not, feel free to get up with us for another, short consult to talk about it some more if you think maybe something different might be helpful.
Are there any treatments that you would recommend or not recommend for her situation?
I would want to talk with a doctor a little in depth about statin use, or, some of the meds that they might use for atrial fib with her, making sure that they're thinking about the dementia in addition to that and not really going for trying to get tight control on things. The main thing is that she's more likely to, have a stroke, but we already know that. I mean, she's already having those. Yeah, I mean, and so medication management for somebody like her is probably not what I'd say, ultimately, and are we talking, do you want to do surgery on someone like her? And my sense would be, yeah, I don't know about that. Because, being under anesthesia, trying to figure out how you're going to manage manage the surgical procedure stuff, putting in a pacemaker, you really just want to go, drugs and shocking the system. I mean, how much do you really want to do with that? So, I mean, there are meds, but you really want to talk through, okay, so what are some other things we need to think about at the same time? So, but feel free to, get back with us after, if you do hear anything more, then we can talk about, what else can you do and should be looked at. But the meds, they can have impacts on people's sort of, in general, they're just their overall sense of well-being. But they are sometimes things, atrial fib can be something that can sometimes help. But I would say, not necessarily, whether you're going to do a catheterization of the heart. I'm trying to think through all the possibilities. Meds, you try to control the rhythm of the heart. Yeah, they can. I mean, and the other thing is, if it's also caused by emotions, it's hard to get that to even out, honestly. I mean, with just drugs, because it's caused by her brain having a, oh my God. And I don't know that you can give medications for that, because her brain is still going to do that occasionally. And it's going to make her heart do that thing that it does. And otherwise it may not have a lot of atrial fib going on. But whenever she gets panicky, it goes into atrial fib. Well, what causes her to get panicky? Things that are unfamiliar, things she can't understand, thinking something has happened that it hasn't. And so you start wondering if you're chasing your tail a little bit. And that's the frustrating part, is sometimes when people are in that space with dementia, it's possible you can find the meds that work just right. Typically, the anxiety-induced ones tend to be the least responsive in a reasonable fashion, unfortunately, because it's coming from the brain more than it's coming from the heart, frankly.
So is there any meds for anxiety and all of that?
They can be tried. The difficulty with them is they don't stay on board very long. So then you increasing them, and the increasing anxiety meds do affect your brain. And so it makes your brain less alert. And so although you're less anxious in the moment, then when you come out from under it, then you're more confused about what has been happening and what's happened. And then even more, they're worried about people having poisoned them and making them not be able to think right. And who's doing this to me? And so this spiraling phenomena is sometimes made worse by everybody starts throwing more drugs in the pot. And so we have the medication for the heart rhythm, then we have the anti-anxiety drug, and then we have to put on a beta blocker, so that, and pretty soon she's on 8 meds. Plus now they're looking at, maybe she needs a thyroid med on the top of that. And it's like, wait, hang on, and does she need something for sleep? And then this is where, it can get really quickly, you're thinking, how do we end up here? Kind of thing, because the idea of putting another med, and unfortunately we end up with side effects and interactions that can get pretty tough. So it's best that maybe a geriatrician, maybe seeing if you can find somebody who's willing to come to the house, to the home, to just get better measures on how she's doing, maybe looking at a Fitbit system to see if any of that might be able to give them better data than trying to take her into an unfamiliar place and do stuff there, which seems to be her least comfortable place to try to do anything.
Mm-hmm.
Yeah.
Thanks.
You're welcome. Sorry it wasn't like straightforward, try this and this will work. I mean, but it rarely is with dementia.
Right.
Oh, thanks for being willing to ask the question and taking care of your mom though, because that's got to be wonder how hard your heart's doing.
Yeah, I know it.
Yeah. Okay, thank you. Rachel, what we got?
So our next question is from Elaine, and she said that her dad is in the late stage of dementia, about stage 6, and he has stopped sleeping at night, even though he's on sleeping meds. And so she's like, what can I do?
Okay, is he sleeping in the day?
Not always, so
Okay.
it seems like he can go on days without sleeping.
Okay.
He'll maybe take a quick nap during the day, but then he still wouldn't sleep at night.
Okay, what's he doing when he's awake?
He will either get up to pee or he will start trying to take apart the bed sheets or go through drawers. He'll say he needs to go to work, all kinds of stuff.
Okay, so he's wanting to be active and involved in something or doing something when he's awake. He's not just awake and comfortable being awake. He needs activities to do. And yet the activities he does doesn't always make a lot of sense, but to him, they make sense. And he needs to be very busy doing them. Do you notice whether he's equally busy during the day as well as the night? No.
So he seems like calmer during the day. He's more active at night.
Okay. Is that a long term? Has he always been a night owl or is this new?
This is starting to get worse as his dementia is getting worse, it seems. I don't remember him being a night owl.
Okay.
We have him on at least two different medication and CBD to help him calm down at night.
Okay.
It seemed to have worked for a few months, and now it seems like not working at all.
It's not working as well. Did they give you a specific diagnosis of what kind of dementia he had?
No, they did not.
Okay. Okay, I'm going to let the team here ask a few other questions because they're very familiar with different dementias. Let's see what kind of questions they want to ask you, Elaine, to try to sort out a little bit before we start talking about, okay, so you're not sleeping because he's not sleeping at night. And when he's busy at night, it's not a comfortable busyness. It's a sort of a distressed busyness. It's, yes. I need to be somewhere, I need to be doing something. And yet that doing has a frantic edge to it or an uncomfortable edge to it.
Yes.
And it's a lot less.
He's unstable on his feet.
Okay, so high risk for falls. Has he had some falls already?
Yes, several over the years. Yeah.
Any head injuries or mostly just sit down, plop down falls?
His injuries is mostly in his spine. He has a couple of cleft vertebrae.
Okay.
Nothing in the hips. And he did bump his head before, and we did have a CT. And the doctor did see a little bit of bleeding in the brain in the area that doesn't really impact. They said, it shouldn't impact his function, and it looks like something old. They said it's in the part.
One part of your brain doesn't impact your function. I'm like, what?
Yeah,
what
they said it's a few millimeter of what they could see, very, very small, and it looks like it's been there for a while, so we don't even know
how long it's been there. If it was like an adolescent injury or a young person injury or whatever.
No. It actually is not something. Actually, let me take that back. They compared it with last year's CT scan. He did not have it. So it was sometime in the last 12 months that he's had an injury. Yeah.
Okay. All right. So it has happened relatively recently, within a year.
Yeah. Yes.
Yeah. Okay. And I beg to differ with them. There's really not a part of your brain that you can have an injury and it doesn't sort of affect function somehow. Now, it may not affect thinking or it may not affect staying awake at night, but it's going to affect something. I mean,
with every fall, his dementia has gotten worse. And with every hospitalization, he's gotten worse.
Yeah. I mean, that's not true. I mean, that's, like when you fall and you rack your head into the brain case or the skull, something's going to happen. I mean, that's the tricky part about falls, is they have consequences. And what they are they're concussive events. So it may not be that you had a full concussion where you lost sort of your arousal and alertness, but when your brain slams into the front of your skull, there's some bruising and some bouncing that takes place. And what we're finding out is that actually has impact more than we think it does, because we have so much function that if we have that happen early on, we don't notice it. It has to be a pretty hard hit. But as people's dementia progresses, it can be less and less of a hit and more truly just a fall forward. And because of the loss of brain tissue, the reduction in brain size, your brain is actually slamming back and forth inside the skull a little bit and causing more harm than we would otherwise see. And so although it doesn't shred or rip the brain apart, it does damage it. And so we start seeing more results of the brain being less functional and less alert and less able to compensate. So other questions, folks, Beth or Rachel or Cheryl or Lynn, anybody wants to ask or find out about Elaine's dad? Anything you can think of?
And my head automatically goes back trying to address the issue that you brought to the table was, what is he doing during the day? So what does his day look like? Can you describe a little bit about what he does?
Yeah, we actually have 2 full-time caregivers during the day, and they try to keep him awake. He takes walks. We also have games for him to play, drawings. And so he'll draw and he'll put puzzles together. We even invented activities like folding laundry, separating beans, whatever he's willing to do to keep him engaged in watching TV for a bit, singing music. We're just trying to find everything. We even bought a robot cat for him, which he loves to pet. Which was, amazing. At the beginning, he didn't take to it, but now he plays with that cat every day. He takes some naps. He eats on time every day, 7, 12, 6 o'clock every day. My mom is there, then the 2 caregivers. He has agitations. He had agitations this morning because I think he didn't sleep hardly at all last night. But in the afternoon, he seems to be better, but sometimes in the afternoon, he's worse. He's got the sundowner thing going in the afternoon.
So what meds is he taking, Elaine? Now you've got me wondering what meds he's on.
So at night, he's mostly besides constipation meds during the day, at night, he's mostly on trazodone, gabapentin, and CBD with melatonin.
Okay.
And so because he has back pain, we do try to give him Tylenol whenever we notice the pain.
Okay.
But if we overdo Tylenol, he stops eating. So, yeah.
Has he ever been a guy that took very many meds during his life?
No, actually the opposite. He never takes meds. So, this is kind of something new.
What's his appetite like?
It's actually pretty good. If it's something he likes to eat, he'll eat by himself. Once in a while, he gets a little confused about which plate to eat from, but he's mostly eating by himself with a little bit of direction.
So if you were to offer him these same activities during the night, would he have any interaction with them, or he doesn't really engage with those activities at night?
We have not tried that. So we're just today, I started, just last couple of days, kind of dawned on me that, hey, maybe he just doesn't want to sleep at night and we're making him sleep. And so I'm starting to suggest to the caregivers, maybe at night, just have him sit in the same recliner chair and he's awake, try to engage him in activities. If he wants to nap, let him nap. Because so far we've been trying to make him sleep. Yeah. And it's starting to not work.
Yeah, I'm wondering whether the phrase Lewy body dementia sort of pops up in my mind as somebody who's having a lot of difficulty. How is he? But he's doing some fine motor activity stuff.
Yeah,
Have you
he's
noticed-
feeding himself. Yeah,
Okay,
he's
so-
even putting puzzles together. He's
Yeah.
able to, you know,
Cool.
we have a game where he threads, you know, a string through a number of loops, and he gets better at it as he's doing it. He's learning.
Yeah.
So,
But historically at night, he would have slept at night. It, you know, not a problem at night. What did he do for work?
he was a engineer. He was a
Okay.
computer hard drive engineer. He was a,
Okay.
before that, he was a physics professor.
Okay, so very a brain guy. It was a
Yeah.
very brain-oriented guy. And did he do a lot of work at a desk or a table or anything like
Yes.
that? A lot of
Yes.
computer kinds of stuff and
Yes.
yeah, and that's no longer something he can do with any accuracy at all. Yeah. So that's a missing piece for him, but he seems to enjoy doing these tasks, these activities and being successful at them.
Yeah. Yeah. When we praise him, he's happy. When he's helping us fold laundry and we tell him he's doing a good job, he's happy. He wants to be productive. He's always been a very productive, active
guy.
person. Yeah.
Okay, so I wonder whether, are there staff that could be active at night and rest in the day?
Yeah, we actually hired nighttime caregivers focusing just on the nighttime.
Okay,
But up to this point, they've been sleeping when he's sleeping. So the goal has been sleeping at
yeah.
night. The goal hasn't been engaging him in activities.
Yeah. And I wonder if some people literally flip their day and their night. Nighttime is an uncomfortable sort of uncomfortable, scary time because it's dark and there's less stuff and you can't quite figure things out as well. So keeping people engaged and active at night, they feel better and then they can go to rest and sleep in the early morning and through the early morning and through the mid morning. And then they wake up late in the morning, getting close to lunchtime, but they do much better because their relaxation and their deep sleep occurs in the early morning to mid-morning range rather than at nighttime. So it
That
sort of
seems to
shifts
be-
the clock.
Yeah, that seems to be the case. So I'm just wondering, should we just take him off of sleep meds and just try to keep, you know, just have the caregivers just be active with him at night?
I would definitely, you know, think about that because I think the trazodone will help get him to sleep, but it won't keep him asleep. That's the thing about trazodone. Trazodone helps you go to sleep, but it won't keep you asleep if your brain is telling you to wake up and be active.
I see.
The CBD, I mean, it's certainly, I mean, if you're trying to reset the clock, does he go outside in the morning at all?
Sometimes the caregiver will take him outside walking. They usually go out walking every day for a little while.
Yeah, so it seems like you're doing everything you could to reset the clock naturally. I mean, you've done a really good job with doing that. That's not working, would be what it seems. And so it's time to really go, okay, so he wants to be active at night. What if we let him be active at night and then come awake and alert, you know, go to sleep in the early morning to mid-late morning and then wake up and run the day like off by about 6-8 hours, you know, and see what that does. With how much trazodone is he on? 75 milligrams or around about that, or?
Let me think. No, he's on more than that. He's like on, yeah, he's on 100 something.
Okay.
Yeah, 100, and I think we just started trying 150 even.
Yeah, so if you want to take it back down the way it was brought on board so that you gradually reduce it rather than just stop it.
I see.
Classically, so dropping it down, titrating it down if you're going to try it to do that. And I would leave the CBD alone and question whether or not the melatonin is buying you anything and maybe back off the melatonin and just see what happens, or even give it at a later time in the night kind of thing. And just see what that is, because the gabapentin, I don't think that's what's doing the thing that you're having trouble with. Yeah, it just seems like his sleep cycle, he's truly switched on his sleep cycle and shifted it a good bit. And our effort to keep him active and awake, okay, well, I'll be active and awake, but then I still can't get to sleep.
Yeah,
And
I
then
think
he's sleep deprived.
I think the sleeping, his activity seems to be more anxious and more weird at night than during the day.
Yeah.
And so I'm wondering if the sleeping pills is making him even more confused. So he's, he's pulling on, like pillowcases, he's doing all kinds of weird things he doesn't seem to do during the day.
And he may be really fatigued out too, but he can't rest. And so he goes to sleep briefly, but then he's right back up.
Yeah.
And he's really sleep deprived. And so we're seeing really severe sleep deprivation.
Yeah. Okay. All right.
It's worth a try, that's Beth, you've got some new research on melatonin. Go ahead and share that out too.
Yeah, just that they're kind of looking at it a little bit more seriously. Recognizing that it describes some of the side effects, but it may be effects that we need to be thinking about all medications. And it's not anything that's going to shock anybody, but it is a drug and there are behavioral aspects to it. There's a body addiction aspect to it. But then if you've got something like dementia that messes with your rhythms and changes things up, and I think you guys are really, it just sounds like you're just amazingly approaching this with unbelievable flexibility and recognizing that, okay, I need to look at the fact that pulling at things tells me a message that there's some sort of agitation and it's hard to suss out whether or not it's a pain from his back, because we know that chronic pain in the back is such a horrible thing to manage. But the melatonin as well as the trazodone, I love the idea of really slowly titrating those off. It may be worth it to have a clinical pharmacist take a look at his meds and see what would be, and this could be in combination with a physician, but the clinical pharmacist can look at the meds and see which one is going to cause the biggest problems first. So we call it like these brown bag visits. You literally bring everything and the whole story of who's taking the med when and how often. And they can tell you, okay, actually melatonin, you want to just kind of slowly, it's going to be some surprising things that the clinical pharmacist may come up with. So this idea of going slow to reduce some of these may be the way to go. But my guess is, like Teepa said, the CBD may be the last one you want to remove. Just hearing some of our friends, and it sounds like as we're chatting in the background, the possibility that there may be a new dementia here in the picture that's really messing with this great plan and these awesome care partners that you've got engaged and all the amazing things and skills that your dad has that may be messing with the plan, it sounds like. And I wonder if Teepa can speak to that a little bit, some of our hunches about Lewy.
Yeah. So, wondering whether the nighttime wakefulness and the anxiety at night is more of a Lewy phenomena than it is a straight out Alzheimer's or vascular dementia. And it also sort of affects falls, and it affects heart rhythms, and it affects distress state. And it can also, it can really mess up sleep cycles. And so people really cannot sleep in the night, cannot do it. And so whatever we try to do to help them sleep in the night, it doesn't help because they can't turn it off. And so they're much more relaxed and can sleep when there's daylight and when it's light out, and their brain can relax into the light. And then they're able to rest in the morning daytime, and then be back up and active in the afternoon and evening. And that's
I actually asked his doctor. I was questioning whether he has Lewy body, and she flat out told me no. And I don't know how she would know that.
How would she know that?
Yeah, how would she know that when she hasn't really diagnosed her with what kind of dementia she has? And when I asked if it's Alzheimer's, and she said that it's difficult to really clearly determine Alzheimer's, so I'm not getting a whole lot. I'm talking to neurologists, talking to GP, and I just feel like I'm doing care coordination between them for my dad. I'm trying to get my dad.
Like you are.
I'm trying to get my dad into a memory clinic so I can get a geriatric physician, a memory care physician, to really look at him.
Good. I think that would probably not be a bad idea, because it sounds like, people get in their minds, it's probably one dimension. What I would say is what we know about dementia is it's a party. Once one gets going, it's the other guests get invited to the party very frequently. And so it's a primary of Alzheimer's, but a secondary of some Lewy body disease. And so what it means is there's a secondary abnormal protein getting active, and it can take place in the core of the brain where you have pain management. So, it affects pain. It can affect blood pressure, heart rate, sleep cycles, hunger, thirst, anxiety. And it can really, blood sugars. And so it makes it.
The neurologist was trying to put him on antipsychotic meds. We tried that and no good. I took him off.
Yeah. When you say that, tell me what happened.
He was getting really weird in the afternoon. He started getting up, starting to grab onto door jambs and start trying to take apart his walker. It's like all kinds of weird things. And he wasn't engaging. He was starting to not be able to feed himself.
Yeah, so there you go. Yeah. It's called extrapyramidal toxicity. And so, those meds can affect the extrapyramidal, which is the sort of cerebellar function and balance function in the human body. And so it's a very core function. And so those meds can have really significant impacts for people, and particularly for people with Lewy body disease. It's well known to be high risk for toxicity. And so it's really that one of the reasons for the black box around those meds is people with Lewy body disease. So it's like, that profile makes me real uncomfortable, sort of. I mean, that's one of those ones where, there's always exceptions, but as a rule, that is not the kind of drugs you want to go to.
So is it generally for his issue, we just keep him off of meds then?
For many, so CBD is sort of many of our, again, people who are living with dementia, who are living fairly well with dementia, have come to the conclusion their best bet is to stick with some CBD, work on some life changes, work on really having a partner who's supportive, and really go with as few meds as you can go with so that you don't end up getting yourself in trouble.
Got it.
Yeah.
We're starting to realize that.
Yeah, because adding drugs onto a broken brain doesn't improve the function of the broken brain. It makes it really difficult. So trying to find those balance points.
I think they gave them to us because he'd get particularly agitated, sometimes could be violent at night.
Mm-hmm. Yeah, and trazodone is, and so the antipsychotics sort of try to dope down the behavior. I mean, they want to try to control the behavior with these meds, but they can actually backfire on people with Lewy body particularly. Or they make them so unable to control that they can't even control chewing and swallowing and bowel movements, and they get stuck. And so, constant, really impactions and problems with urinating and difficulty even sitting up and eating and swallowing and having saliva production.
Mm-hmm. Mm-hmm. Yeah. Okay, thank you. This is helpful.
Yeah, I mean, it varies, but that's certainly a concern.
Yeah, and the issue with melatonin was two things. One, it's not regulated by the FDA in the United States. So you really don't know quite what you're getting. You'd have to really go to a reputable provider that's very transparent. If you do and you find melatonin is a good fit for your person, but it's really, they're finding that there's the long-term brain health is an issue. And if you're using it every day, there's the mechanism. It's almost like you have to read into a little bit, but it's just not as safe and straightforward as we think. So in other words, like you take too much vitamin C and it's a water-based vitamin and you kind of just get expensive urine. You can overdose on anything, but melatonin isn't quite like that. It really does stick around. And so if you've got someone who's got confusion and agitation, they're taking melatonin and they're not sleeping, then that's when we're looking at the possibility of, is this something that's not working for the individual? I think it's that awareness piece that you guys are doing so well and recognizing, okay, if this isn't working and we're seeing other things that aren't like him, then that's when it's kind of that pause. Maybe this isn't the thing, regardless of whether or not we're right about another dementia on top of his existing.
Yeah. Yeah, you guys are confirming what I'm just now realizing is we're trying to treat him like people with someone with normal sleep pattern, and he's just not. And we're trying to fit him into our lifestyle, and he's not fitting into our lifestyle.
Yeah, and you are really committed to being the best for him. And so you're willing to do that transition. It's hard when there's only one carer and they have to be up in the day. But it sounds like you might be able to have the flexibility to try out an alternate sleep cycle for him and see how that plays for him.
Yes.
Yeah.
Thank you.
Oh, you're welcome. Thanks for asking. It's a great conversation because we see it a lot, particularly in the later states and with Lewy body. People often have, holy moly, huge problems with Lewy body sleep. And you know, it's a big deal for folks to figure out that sleep pattern.
Yes.
Cool.
Thank you.
Thanks. You're welcome. Rachel, we got it. We got another one that we want to sort of try something with here.
Oh yeah, we've got more questions. So this one is from our one of our friends on YouTube, and it's a little complicated, but I think the basic idea is that the dad is showing some brain changes, and they're having a hard time getting him to go to the doctor because he's not remembering about the appointment. He gets upset. It turns out the real question isn't so much about getting the dad to the doctor, because I think it's kind of I don't think he's going to go. I don't like it. But the neurologist said, oh, well, I think he's basically fine. He does show some deterioration, but he's mentally able and he's 88. The problem is that the brother doesn't think that the dad has dementia because the neurologist said that he was still mentally capable, or whatever the term was. So how does this person and her brother get on the same page when the dad won't go to the doctor and the doctor's not helping? I think that's the gist.
Okay, so the guy saw a neurologist at some point. Is that it seems like? Okay, and the neurologist at that time at 88 didn't establish a baseline and say, you know what, we need to sort of see how things are looking, because honestly, I've never seen you before. I can't tell you for sure if what your experience is normal for you or you're changing. I mean, I can't honestly tell you in just one visit because I don't know your history. And this is the first time we're getting together. Now, how many doctors would do that for you, do you think? Say, I'd love to be really transparent with you. So I've got to be honest, I don't have a baseline on you. And the first thing I'm going to do is establish a baseline. So we can find out if this is just the normal you, this is just how you are and who you are and you're typical, or you've got something going on that might be progressive and chronic and is affecting your life. I mean, who thinks the very first time you walk in and it's like, oh yeah, I can tell everything. It's like, I might pick up some hints and clues. And I certainly, if we're waiting until the symptoms are pronounced, it doesn't take very long to go, wow, there are a lot of things going on here. But to be able to make a statement, you're fine. I don't think there's any problem with you. You're 88. I don't see that as a very helpful way of looking at somebody if I don't know their background. There are difference between NASA scientists and people who work in a factory about their brain to start with, probably, how flexible and different was their brain. So if a NASA scientist is saying, I need to find the utensil with tines, when he's describing, I'm looking for a fork, my brain goes on high alert, because although those are very fancy words, I don't know many NASA scientists who need to use a utensil with tines to describe a fork unless they can't find the word fork. And that's rarely something they'll do. Or they say, the vehicular that I came in. And you're thinking, the vehicular? Are you talking about the car? Yes. Okay. Where I start hearing very fancy words for things, that puts my antenna up that's not normal. I don't expect NASA scientists to use those fancy words to come up with regular words. So my antenna's on high alert that something's going on here. But it's surprising to me how many professionals go, well, he sounds fine. And I'm like, really? I mean, he's describing things as vehiculars. Well, I've done something like that. It's like, you have? Tell me about that. Because it's like, I'm sorry, I don't know that that's fine. Now, could he live his life still at this time? Yeah, so I guess we wouldn't absolutely call it a dementia, but I would certainly say brains are changing and well worth looking at, because that's not a pattern I would expect. But it's remarkable to me how many professionals, and I'm talking medical providers out there, nurse practitioners, people out there, are willing to say, well, he looks okay. I mean, I think he's doing all right, and call it MCI when I don't have enough data to do that. I mean, you need more data to make a statement. I think he's fine. I can have something to say, wow, I'm seeing some things that make me want to do a little more work to find out what's going on here. And let's double check some of the other things that might be, but it feels like something's happening. But to say, oh, I think he's fine is sort of a ooh statement. So I agree that the person that they went to see is not my first choice at a follow-up. If I were going to do a follow-up, I wouldn't bother going back to this person, because it sounds like what I need to have happen for a better evaluation of what is going on is somebody who's curious, not judgmental. And that sounds a lot like somebody who's making a judgment call versus somebody who's really curious enough to try to get enough information. So given that Dad isn't really excited about going somewhere now, and my question would be, I wonder if he got scared or a little worried about going to the doctor, because, you know, it was really hard for him. It did create an emotional memory of that got really uncomfortable. Wonder if there are some things you can do online or you can do in the home that would start to help you notice something isn't quite what it should be. So for instance, yeah.
We have a little bit more information
Oh,
that
we do. Okay.
her dad does show changes. He's had the certain behavior like refusing to go to the doctor, etc. But he's now forgetting the name of his wife and his children, and he even forgets to eat sometimes.
Oh dear. All right, now we are no longer in the beginning stages of something changing. We definitely have something dramatically significant going on here. So we're not even in the early signs and symptoms of something might be going on. This is not MCI. I mean, this is brain change of significance. He's not recognizing familiar people. He's not able to identify when he's hungry and when he should eat. He's making mistakes on sort of what we would call daily life. So that is definitely something has changed, whether it's due to a dementia or whether it's due to poorly controlled blood sugars, poorly controlled blood pressure, problems with circulation to the brain, problems with thyroid disease, difficulty with, you know, he's taking his medications inaccurately. There are so many possibilities. We don't want to use the big D word yet, but we certainly need to say, wow, those brain changes are significant. There is nothing normal about this stuff. Nothing.
So how can we get the dad to the doctor, or how do we get everybody on the same page?
My suggestion would be, does anybody have healthcare power of attorney yet? Okay, and if not, I would be interested in getting some video of Dad's actions and interactions and ability states and share it with a medical provider and say, this is what I'm noticing, and these are concerns I have. Would you like us, he is not interested in coming in to see you. Do you have anybody you can recommend who will do a home visit, who will come into the home and try to engage him and start some interactions with him? So rather than trying to get Dad to someone, is there a way to do telehealth? Because we're still seeing use of telehealth, so we could do something on Zoom if Dad would be willing to talk to somebody on the computer, if there's any background of doing that. or whether a nurse practitioner, there are some practices that do send people to homes because trying to get people into offices is challenging. There are equal numbers that don't do any of that. So finding a practice where you can work with them to raise concerns. And the tricky part is a sibling, because it sounds like the sibling is really committed to nothing's wrong.
And they have no power of attorney.
And there is no power of attorney. Is the sibling somebody who's in the same space and in the same town and in the same level of involvement? Or are they at a distance, or they're less involved, or they just do telephone contacts? Because that's one of the things we want to find out is this one of those things that we need to figure out what's going on between the kids, the siblings, before we try to deal with the dad thing. So break it into two parts. Asking the brother, tell me what you think is going on with dad, because I'm concerned and I know you're not. Tell me more what you think is not happening, and because I'm concerned about these three things. And pick your top three priorities that you think are ones that could impact wellness. Tell me what you're thinking.
So we found out that the brother and she are the main caretakers.
Okay.
And the brother resents the dad, thinking it's an attitude problem. And yes, the brother is in the same city.
Okay, so you're thinking dad is having an attitude, that he's just being stubborn and uncooperative.
He's
And
just not trying hard enough. If he would try harder, it
yeah,
would
so
work.
you're feeling it's more that. Do you think it could possibly be like an anxiety or depression? I mean, because I'm wondering whether not trying.
You're
might
always
be-
just making excuses for him. But really, I think it's just he's just got this attitude. And if you just get over it, then he'd be okay. And he just
So
won't.
you're pretty sure it's just attitude. So I'm going to ask for a big favor.
What?
I'm going to ask to have somebody who knows about attitudes in older adults and about healthcare in older adults. Other than us, the two of us, I don't want to argue with you. What I want to do is see if we can figure out what is happening. And if I'm wrong, I'll eat crow, because I truly do think there is something. And what I hear you saying is you think it's just his attitude and he needs some tough love. And if we can get somebody who's skilled to look at him and to say that you're right and I'm wrong, I'll say you're right and I'm wrong. I'm sorry. You were right to start with, but I'm afraid we might be missing something. And I don't want to risk dad's rest of his life making a mistake that we could have done something about if we quit arguing enough. So what did I go for instead of trying to get him to see it my way? What was the big difference? Beth, did you notice what I opted for there?
Unfortunately, I did not. I was doing a chat with someone to figure out. It's like,
Cheryl, were you? Okay. Cheryl,
So
were you
Teepa.
noticing? Yeah.
Yes. So, oh, sorry. Go ahead.
Go ahead.
Whoever. Go for it, Cheryl.
Okay. So I noticed that you brought in someone different, someone from the higher up. So we're going to work together at this to reach out to someone.
Well, I said we were in different places. I agreed. We can't agree. We are in very different places, and I'm asking you for a favor. I get it that you think it's attitude and I think it's something different. I'm willing to say I could be wrong. If I'm wrong, I'm willing to say I was wrong, but I don't want to risk dad on this and just us having an argument. So I'm asking for us to figure this out with somebody who might be able to give us better data than either one of us. We're both guessing.
Yeah.
I mean, and getting somebody who's more of an expert. I want somebody who's good though, who really is like a geriatrician or something, not the guy that, said dad's okay, but he didn't even spend but 15 minutes with him. However long he spent, because and we need somebody who's willing to come spend time with dad because he doesn't want to go anywhere. And I mean, trying to get him somewhere, I don't want to have a fight with him either. I mean, I frankly don't want to fight because I don't think it's going to serve us well. Because if it is something that needs support, we're going to have to figure this out, how we can work together. So Rachel, thoughts from your side of the street?
Yeah, you asked a favor and the lady did say thank you so much. So I think you gave her some things to think about and maybe try.
Okay, cool. All right, well, we are running out of time for tonight for our Ask Teepa Anything, and I'm sure we had some we didn't get to, and I'm betting that Beth was doing some typing for somebody and maybe helping them, and I've got a feeling Cheryl was probably doing the same for some other folks, and we know that there are probably more questions in the world than we can ever get to. Matthew, anything in particular out there in the YouTube world that we need to listen to or pay attention to?
Yeah, so right, Teepa. Lots of questions tonight. A lot of folks looking for some support, and I did put in the chat in a number of places where you guys can get up with us if we didn't get a chance to get to your question tonight. So you can certainly reach out to us at the consults@teepasnow.com or the web link that I put in there that will bring you to where you can schedule a phone consult with one of our skilled members. And the first 30-minute session is free. So please, if we didn't get a chance to meet your needs tonight or get to those questions, reach out to us at those places and we'll certainly connect with you and help to support you.
And some of the questions we'll try to get to on Teepa for 10 in the mornings, because sometimes that's a time that Matthew and I or Rachel and I will do a recording of a particular content area that people are curious about, and we are trying to figure out how to be helpful to people. So thanks to everybody who came tonight. Thanks for all the support, and thanks for all the questions, because together we're better than apart. And when we work with one another, we learn things from one another. So thanks for being in the world and being committed. Thanks, everybody. Have a good evening.